Good evening. Thanks for coming, and these are the lucky few that were able to find parking tonight, I see. I am part of the team that works at Lucile Packard Children's Hospital in the Prenatal Diagnostic Center. We're a very busy center. We do thousands of ultrasounds procedures per year, and I thought today I would give you a little tour through the labyrinth of prenatal diagnosis. So just first of all, conflict of interest. I have, unfortunately, no financial stake in any of these commercial entities that are related to this talk. However, I am a site PI for a study with Natera, and I serve on their advisory board. So this is an older slide that maybe 3 years ago when the choices were already numerous, and they included those you see on this slide. And I think these actually are even increasing as we speak. The whole reason for prenatal diagnosis is to help a woman figure out what's going on with her pregnancy and try to find out if there's anything that she needs to be prepared for, so that she can either decide to do something differently or just have the knowledge. And probably the most common thing that we're looking for in genetic diagnosis is Down syndrome. Down syndrome typically looks like this. It presents with flattened faces, upslanted eyes, downturned mouth, the single palmar crease, clinodactyly, which is this curved fifth finger, and sandal foot toes, which is a gap between the first and second toes. This is becoming more and more mainstream. You probably, if any of you watch Glee, there's a girl with Down syndrome on that show. They can be very very happy individuals. So the tests that can look for this are diagnostic tests. These will tell you for sure if this baby has Down syndrome or something else like that. The first diagnostic test is called a chorionic VILLUS sampling, which is performed between 10 to 14 weeks of gestation. The second is amniocentesis, which is performed between 15 and 20 weeks gestation. So just a little history. Amniocentesis was first performed way back in 1877. I often, as I'm doing these tests, people say, well, how long have you been doing this? Has it only been the last 10 years? It's actually been a lot longer than that. The first one was done in the third trimester and was performed to relieve polyhydramnios, which means too much fluid. So they were done without any ultrasound guidance. The physician just palpated, figured out where the fetus wasn't, and put the needle in, and hopefully was lucky enough to get fluid. The first genetic amniocentesis done was actually to check for fetal sex in the case for hemophilia, which is an X-linked disorder, and for which only males are affected. And this was done in 1956. So if you look back in the early amniocentesis, they may look something like this. So here's the ultrasound machine, which sort of engulfs the woman. And here's the needle, some contraption which has a guide. And this was what it looked like in the 1970s with the VILLUS on. I think we've come a long way since then. And our machines typically look more like this. Now we have modern day real-time guidance. So we have a screen at which point we can actually watch the needle go in as we're doing it. And the patient watches also. Simultaneous visualization of the needle tip throughout the procedure. And here you see a picture of the tip of the needle, and here's the little baby's hand. And patients always ask, do they know that you're doing the amniocentesis? And we obviously can't ask them, but sometimes you get a strange feeling that they sense something because their hands tend to try to grab this instrument. However, reassurance that we have done many tens of thousands of procedures, and we're very good at dodging curious babies. So this is the second procedure called chorionic VILLUS sampling, which actually came later than amniocentesis, but is done earlier in pregnancy, and it's done between 10 and 14 weeks gestation. And in this picture, you see the embryo here and the placenta, and all this filamentous stuff is actually chorionic villi, which is the developing placenta. We can do CVS one of two ways. One is through the cervix, which in this picture, you can see the catheter, the line there, and the placenta is this gray area, and the fetus is down here inside the sac. So if you look at the diagram, you can see that actually we're going through the cervix, and we're threading it through the cervix and into the placenta and not even entering the sac at all. That was the first way of doing CVS, and that was associated with some 3 to 4% risk of fetal miscarriage. And then a group in Italy developed a second entryway for CVS, and this was called transabdominal CVS, where we went through the maternal abdomen, and you can see here the needle tip going through the mother's skin, which is right here, and it goes into this gray area, which is the placenta, and the fetus is down here in the sac, which is not disturbed at all. And so given these two very different approaches, and yet getting the same villi, the risk for CVS dropped markedly to now where we consider it to be as safe as amniocentesis in people who do a lot of them. So in skilled hands, our risk for amniocentesis and CVS is about 1 in 300. This is a picture of what we obtain at chorionic villus sampling, and we put it into a petri dish. We check under the microscope, make sure that we actually see the correct tissue and that there's enough tissue before we let the patients go home. So again, what is the risk of amniocentesis versus CVS? Well, in the 1980s, the CVS loss rates were about 1%, using both transabdominal and transcervical CVS. And the amnio loss rates were quoted to be about 0.5%. However, recent studies show that CVS is no more likely than amniocentesis to cause miscarriage when performed by an experienced provider. And experienced, I would say, would be someone who's done several hundred procedures, perhaps thousands, depending on how old you are. But given that experience, with more experience, the safer it becomes. So who should have diagnostic testing? Well, in the past, it was typically women over 35 were advised to have diagnostic testing. And why is that? It's because the risk of a chromosome abnormality in a 35-year-old woman is 1 in 150. And this became slightly higher than what was thought to be the risk of the procedure, which was at that time quoted to be about 1 in 200. However, if you look at overall population risks, 80% of Down syndrome cases actually occur in women under age 35 because they tend to have more babies. And this may be changing because more women are having children past age 35. So there's even more risk in these older women who have an increased risk for Down syndrome. So should we be offering prenatal testing to everyone? And this became a question, like why are we singling out women over 35 and not offering this to younger women? The ACOG recommendations came out in 2007 after reviewing all the data and all the risks, decided that maternal age of 35 years alone should no longer be used as a threshold to determine who is offered screening versus who is offered invasive testing. And that invasive diagnostic testing for aneuploidy, which is the wrong number of chromosomes, should be available to all women regardless of maternal age. Now, would a 19-year-old choose to have an amniocentesis? I think that's always a good question. We offer it, but we don't necessarily recommend it. And just to be clear, let's talk about what a diagnostic test is. A diagnostic test gives you a definitive answer. No question. It's either Down syndrome or it's not. But it is an invasive procedure because at this time we need to get tissue either in the form of placenta in the chorionic villus sampling, or we need to get fluid which has fetal cells in it in order to grow the cells and get the answer. And so anytime you do an invasive procedure, there's a small risk for miscarriage. We tell patients that they have choices regarding genetic testing and that diagnostic testing carries a risk, and that age is only one factor amongst many others that influence their risk for genetic defects. So let's look at some of these factors that can help individualize their risk. How do we find individual risk? So in determining risk, we use something called screening, and those this is a protocol that we use currently to find out who's at high risk for having a fetus with aneuploidy or specifically Down syndrome. In the first trimester, which is between 10 and 14 weeks, we do a blood test, and we do a nuchal translucency, and I'll go over some of these. In the second trimester, we do it between 15 and 20 weeks. That actually is not correct. It should be 20 weeks there. The first trimester screen consists of an ultrasound, which is looking at the back of the fetal neck, something called the nuchal translucency, and a blood draw, which includes two proteins, one called pregnancy-associated plasma protein, or PAPP-A for short, and the other being free beta HCG. Now let's go over the nuchal translucency. It's usually called an NT. It's an ultrasound measurement of the thickness of the fluid behind the neck, and it's a marker, not an anomaly in itself. It's performed when the fetus measures between 45 and 84 millimeters, which is approximately 11.5 to 14 weeks gestation. Here's a picture of a normal NT. It looks like there's a little bit of fluid there, and this is the area of interest, is this space behind the back of the neck between the spine and the skin. And here's another picture of sort of some of the details of the fetus. We need to have the fetus in this position where we can actually see the nasal bone, the skin, the nasal tip, part of the brain in a certain way, and in order to get this particular measurement. It's very critical how you have the fetus, because obviously if the fetus is in a different position, this little area may not be visible or may measure differently. So there's large quality monitoring to make sure the person who performs the NT is doing it properly, and we all have to submit pictures every 6 to 12 months, and if you fail, you have to submit more pictures, and it's an ongoing source of frustration for some of the physicians, and we're all equal. They don't care who you are. They just look at your pictures. Here's a picture of an abnormal NT, which is the back of the neck is enlarged, so that's extra fluid back there. And why is that? Well, a guy named Kypros Nicolaides, who works in London, discovered that there was an association between an increased NT and chromosome abnormalities, Down syndrome and trisomy 18 particularly. There's also some association with other defects such as fetal cardiac defects or other disorders with altered lymphatic flow, such as an omphalocele diaphragmatic hernia or some of the other abnormal fetal movement syndromes. The procedure is in your physician's office, you draw blood between 10 weeks and 13 weeks, 6 days. That will record the PAPP-A and the HCG that I mentioned earlier. And then the best time, however, is in the middle of this time period, and I'll tell you why in a few slides. And then you do the NT ultrasound 1 week after the blood draw, and they measure the NT, and then you are able to access the results of the blood test, and they put it together and give you a certain risk. Now, one day can throw it all off. So here's an example of a patient who is very eager to have her NT done. So she draws her blood as soon as she's 10 weeks. 2 weeks later, she has her NT done, but instead of measuring 12 weeks like they thought she measures 11 weeks, 6 days. That means that she drew her blood at 9 weeks, 6 days instead of 10, and she would need to redraw her blood. So this is the way the state has a certain criteria, and there's no information for any blood done prior to 10 weeks. So if you do it and you're just a little bit early based on your coming up ultrasound, then you may have to redraw your blood. This is one reason why I like to draw their blood at, say, 11 weeks versus 10. Also, 1 millimeter of measurement can throw it all off. So, for example, a patient has her blood drawn at 10 weeks, 3 days. She eagerly schedules her NT 1 week later for at 11 weeks, 3 days, when she thinks she should be at that 45 millimeter length. But unfortunately, her fetus actually measures 44 millimeters, and this is insignificant in the world of ultrasound because measurement error can vary several millimeters. But according to the state, you have to be 45 millimeters in order to be entered into the program. So she would actually need to reschedule to come back and have her NT drawn. But let's say you actually have your blood drawn above 10 weeks, and then you come back a week later and you do your NT at about 12 weeks, and then you get this combined result which would also would delineate your blood test here and the NT measurement, and then down here puts it all together and says your Down syndrome risk now is 1 in so-and-so, and in this particular patient was 1 in 2,600. And so the same thing is done for trisomy 18 risk. Here it says 1 in 34,000. And we give the patients these risks as they're leaving the NT ultrasound. And their first question always is, oh, is this a good risk? Is this a low risk? And so I made this slide to sort of help people decide, what is low, what is a good risk, and what is not. So here on the left, it goes from minimal to very high risk. And the numbers up here are sort of an estimation of what we think might be high versus minimal risk. So very high risk would be obviously 100%, 1 in 1. 10% is also a high risk. And I think 1% is starting to get in that, oh, maybe not so high. So we're putting that in the moderate category. But anything lower than 1 in 1,000 we think is low, or very low, minimal. And this, fortunately, sort of translates into age. For example, if you're age 20, your risk actually of a Down syndrome baby at birth is 1 in 1,667, which is in the low range. As you get older, your risk moves up. And then by age 49, and that's actually real, so we are having people who are age 49 getting pregnant, your risk of Down syndrome is 1 in 11. So we would put that in the high range. And so anywhere, but the thing is, when you do the screening, your 49-year-old may not have 1 in 11 risk anymore. Because after her blood test and after her nuchal translucency are analyzed, she may actually be 1 in 380, and she may have the same risk as a 35-year-old, which would be a moderate risk. And so that's the beauty of the screening protocol, is that instead of using age, which is completely arbitrary, some of us 49-year-olds are actually more like 20 years old, and that makes everybody very happy. So here is that first step in the integrated screen, which I just mentioned. If the first trimester screen is performed and your risk is greater than 1 in 100, which is 1%, the state has decided we're going to consider that high risk and we're going to pay for diagnostic testing. And that would be in the form of CVS, obviously, because you couldn't do amniocentesis that early. Given that sort of protocol, we pick up about 75% of Down syndrome just using this particular cutoff. If the first trimester screen risk is low, for example, less than 1 in 100, then the patients are encouraged to proceed to the second trimester screen, which is the quad screen, which I'll tell you what that consists of in a few minutes. And if that test is covered, the diagnostic test is covered there if the Down syndrome risk is greater than 1 in 200. And given that, together, picks up 90% of Down syndrome. So here's an example of a patient who was 40, who I first came in with a risk of 1 in 140 for Down syndrome after she did the blood test and the nuchal translucency. So I actually thought about 1 in 140, and that was sort of below the 1% cutoff, but not extremely low. And she thought about it, and she decided, well, I'm going to wait to have my second trimester screen and then put it together, and then we'll get that final result. And her final result actually came back with a Down syndrome risk of 1 in 22,000. So we always tell people, this first trimester risk is just a preliminary result. It may get a lot better because there's 4 more pieces of information that comes in the second trimester. And you may want to wait until you get all the information before you decide whether you want to go forth with that diagnostic test. So I'm just going to take a little digression here to talk about a couple of terms so that you know what I'm talking about when I talk about detection rate. The detection rate is the percentage of affected pregnancies that the screening test will pick up. For example, out of 4,000 pregnancies, there will be 10 with Down syndrome. And if 9 of those are picked up by the state program, that's a 90% detection rate. And that's how the state program works. It picks up about 90%, and we'll pick up 9 out of 10. A false positive rate is being told your pregnancy may have Down syndrome, but it's actually normal. So when you do the test and you do the screening test and it comes back positive, that doesn't mean your baby has Down syndrome. It means that you have a possibility that the fetus has Down syndrome. And so out of 4,000 pregnancies, the same 4,000 pregnancies, 5% of women will screen positive on the state program. And that's 200 people, and they'll be told they're at high risk. In other words, they'll be above the 1 in 100 cutoff, or they'll be above the 1 in 200 cutoff. But they won't have Down syndrome because it's not that common. But because the protocol is set so that we have a 5% pickup rate, it's guaranteed that 200 women will screen positive. It's all based on statistics. So the false positive rate is essentially the same as the screen positive rate. So your screen positive rate is 5%. 200 people will screen positive, and most of those will be false positive. So when people get that call and says, you know, you're screen positive, a lot of people get upset and they think that that means everything's bad. But try to remember that this is just a screening test and that we have not done the definitive diagnostic test. A false negative, on the other hand, is being told your pregnancy is normal when it actually has Down syndrome. And what is the false negative rate of the state program? It's about 10%. So the screen misses 1 out of 10. So since it detects 90%, it's not 100%. All right, so let's go through this again. The first step, first trimester screen. If the risk is greater than 1 in 100, the state will pay for diagnostic tests. With this protocol, we pick up 75% of detection rate, and only 2.5% of people are told that they're positive, which means they're greater than 1 in 100. If you do the second test, that's better because then you pick up 90%, but you increase your false positive rate, meaning that up to 4.6% of women are told that they have a high risk. And so that's usually the case. The more you pick up, usually the higher your false positive rate, and that's the way with screening tests. So for those who don't get nuchal translucencies, let's say you come in too late. You're coming in at 15 weeks to see your OB, or you come in at 13 and a half and you can't get scheduled. All is not lost because you can do serum-only. So if you do first trimester serum, like the blood test, but you can't get into the nuchal translucency, you can save that blood test and you can get a result if you do the second trimester screen. And with both blood tests, you actually get an 85% detection rate, which I think is great. It's close to the 90%. So I think the state did this because, you know, there are places in California where people can't get to a center that does nuchal translucency, and we really shouldn't be enacting a protocol that makes care for those women inferior. And really, it's not very different. So everybody can have blood done. They can have the first trimester, second trimester, put it together and get 85% detection rate for Down syndrome. For those who miss the first trimester completely, there's the second trimester, which is the quad marker screen, and these are the analytes in the quad marker. And sorry about this. This is where I started doing fancy stuff with my PowerPoint that didn't work out so well. We can get an 80% detection rate for trisomy 21. So 67% detection rate for trisomy 18 with the same false positive rate. So that's not bad. And that's, you know, coming in late and just getting the second trimester test done. So what else do we use for screening? Just real quickly, I'm going to go through something called ultrasound soft markers because they're fairly common. They're in the 5 to 6% range of the population, and certainly when people come in and we see those on ultrasound, they're a high source of anxiety. The first one is the nuchal fold, which is similar to the nuchal translucency. It's based on fluid behind the fetus's neck. And in the second trimester, we call it a nuchal fold, and it has to measure greater than 6 millimeters for it to be abnormal. And we used to see this a lot before the nuchal translucency program started. I never see this anymore because I think we're picking all of these up in the first trimester as increased NTs. But if you do see this, then there's about 11-fold increase in your risk for Down syndrome. The second one is echogenic bowel, which is where we look at the bowel of the fetus and it looks brighter than the usual fetus with bowel. And that is also a marker for Down syndrome. It doesn't mean the baby has Down syndrome, but there is a higher likelihood, about a 6.7 increase. The other things that we think about when we see this are cystic fibrosis. So we always ask the patient to make sure they had carrier testing for that, and maybe some viral infections. So we will check a panel of viral vital studies. Short long bone, so short femur, which is the thigh bone. If the fetus has a very short femur, typically less than 5th percentile, there's an increased risk 1.5 times. And then the short humerus, which is this upper arm, if that is short, then there's a 5 times likelihood of Down syndrome. And then finally, well, not finally, but this is one of the minimal soft markers that we struggle with, called echogenic focus. It's always worrisome because it's something that's in the heart, and patients are always thinking there's a problem with the heart. But actually, this little dot is really the normal papillary muscle of the heart. It just shines a little brighter in certain people, and because of its brighter shininess, it's called echogenic. And it has an increased likelihood of 2, which is not much. You know, for example, if your risk is 1 in 2,000, then now your risk will be 1 in 1,000. So is that really clinically significant? We think not. But we do like to look at their numbers, you know, when we see something like this so that we can be sure they are low risk. And then finally, pelviectasis, which is fluid in the kidneys. You know, there's delay in emptying of the kidneys during fetal life, oftentimes in boys, but also happens in Down syndrome babies. And so if you see extra fluid, we increase your likelihood of Down syndrome by a very small likelihood ratio of 1.5. The last soft marker is something for trisomy 18, not for Down syndrome, but this is something called a choroid plexus cyst, which is something that's actually in the brain. And again, this creates a lot of anxiety for patients because it's anything to do with the fetal brain they're upset about. This is actually a normal thing. When the brain is forming, it folds over many times, and oftentimes a little bit of fluid can get caught between the folds and create a little bubble of fluid, which we call a cyst. And here you can see in the brain this dark area, which is fluid filled. And that would be something that would go away over time, not thought to harm the fetus's brain in any way whatsoever, as long as the fetus did not have trisomy 18. And in order to find out if it had trisomy 18, we look at their risk, we multiply by 10. If it's still a super low risk, we think it's unlikely as long as there's no other findings. But if the patient truly wanted to know for sure, a diagnostic test might be indicated. So in the last few minutes, or 15, 20 minutes, I want to talk about the future. All right. And it's just happened, so I had to put this year's on the slide because it really, truly just happened. So for many, many years, actually I remember as a fellow, this was my project. So that was a long time ago. We've been trying to find fetal cells in the maternal circulation because we feel that if we can get the cells, then we can get the DNA from the fetal cells and use that to do prenatal diagnosis. However, after looking at many graphs that look like this, which were trying to find different populations of cells in the mother and try to distinguish the one population different from the mother that could be the fetus and not really knowing which was which and not knowing if this meant anything, the final conclusion from the people that did this, you know, did much better than I did, they published in Lancet in 2003. They said, we believe that recovery of these cells is difficult and not clinically practical. So that explains why my fellowship project never went anywhere, because it really wasn't a very viable possibility. However, since then, there is this other alternative, this thing called cell-free DNA. So instead of looking for the whole cell, which has the DNA inside, we're looking for free-floating DNA. And how does free-floating DNA occur? Well, it happens from something called apoptosis, which is when the cell breaks and all the material spills out, basically. And you'll see that in 1997, Lowe, who was a pioneer in looking for first nucleated cells and then moved on to cell-free, he reported the presence of fetal DNA in the serum of pregnant women. And the cell-free DNA was made up of short segments of fetal DNA that circulated within the mom's blood. And the thinking was that these fragments were thought to be mostly from the placenta. Again, they were in small quantities, all right? So they were readily detected in the patient plasma, and they were detected as early as 7 weeks gestation. But the concentration ranged between 3 to 6%, which was not large, and it did increase with gestational age. And the nice thing was, it was not detected 48 hours after delivery. So one of the problems with the nucleated fetal red blood fetal cell they were trying to obtain earlier was that you would find old fetal cells from previous pregnancies in the mother's blood, and it'd be very confusing. So were you actually getting fetal cells from this pregnancy or from last pregnancy? Well, this being a cell-free issue, it doesn't last, and it goes away, as soon as the pregnancy is over. So they thought, great, now we have something we can use for diagnosis. So how do they analyze this fetal DNA? So you have all these little fragments of DNA in the mom's plasma. What they do is they look at the sequences that go on certain chromosomes. They make tags, that they know these sequences are, and they match them up with these chromosomes, and they start counting. And they count, okay, so how many copies of chromosome 7 do we have that we can see? And how many copies of chromosome 21 do we see? And then over millions and millions of counts, they're able to figure out if the counts are all equal, which would mean, that this fetus is normal, has a normal amount, or is there more of one particular chromosome material than the other? And here's a slide that shows this technique, which is called massively parallel shotgun sequencing. And I just only give that to you because you might read it somewhere and not know what that was, and maybe thought it was something to do with gun control, but it's not. It's actually DNA fragments, randomly sampling DNA fragments from all chromosomes and trying to figure out what the ratio of chromosomes are. And so in this particular one, you see that the chromosome 21 here has a higher Z-score than all the other chromosomes. And so that is how they would diagnose Down syndrome in this particular mother's plasma. Well, this could be very difficult to do because there's so much stuff. And I think in the past, all this DNA stuff was done on gels that was ridiculously labor intensive. They would have radiation-based methods, manually loading electrophoresis gel and reading bases from the resulting images like this. Well, now with technology, we have something called next generation sequencing, which is another term you might hear. But basically, it's an automated way of counting all these little fragments of DNA. And there are many platforms and many methods, but they all basically do the same thing as they count all these fragments very, very quickly. So now, just in the past few months, we have 4 companies that have started to offer prenatal cell-free DNA testing: Sequinome, Veronata, Ariosa, and Natera. And what's even more confusing than their names is that their tests are named something different. So it's just very hard for us to keep everything. And they kept changing the name of their test and sometimes the name of their company. But I think this is now settled out to be this. And you may see, your doctor offering you the Maternity 21 test or the Verify. At Stanford, we use the Harmony test, mostly because it financially made sense in our Medi-Cal patients, but we can talk about that in the question and answer session, and Panorama. So how do these work? Are they all the same? Well, most of them, the first 2, use this MPSS technique that I explained earlier. And again, here's a graph of trisomy, so here's chromosome 21, and this would be normal underneath the line. Here would be trisomy 21. And this would be trisomy 18, or this is not trisomy, but this is chromosome 18. This would be the normal part down here, and then this would be considered trisomy 18. And the same thing for chromosome number 13. So it turns out that the data is only really very good, at least for the first 2 tests, Maternity 21 and Verify, for trisomy 18, or trisomy 21 and trisomy 18. 13 wasn't so good with this particular technique. But here's, this is Maternity 21, the lab report, and this is how it will look like if it came back positive. They just say positive or negative. Verify, same thing, aneuploidy detected or aneuploidy not detected. So it's sort of all or none. With the other 2, Harmony and Panorama tests, they sort of finesse things. They've been using more selective sequencing. So instead of just sort of throwing out all these little fragments of DNA from all the chromosomes. They only do chromosomes 18, 21, and then that allows them to be more specific in their calculations. And they calculate a risk for a patient based on their cell-free DNA counts, how much DNA is in the maternal plasma, which they can figure out, and what the mom's age and what the gestational age is. So, you know, they take into account other risks such as maternal age, and that helps them give a report that looks more like this, where, I don't know if you can read this, but it says low risk, the risk score is less than 1 in 10,000. And this is for trisomy 18. And up here would be trisomy 21, where it says high risk, greater than 1 in 10, I think it says, or 1 in 100. I don't know. It's basically 99% sensitive. So you can be sure 99.4% that if you get a positive result on trisomy 21, this fetus is trisomy 21. The panorama test, the last one I was telling you about, takes even more information. They actually have this very complicated formula that I don't even pretend to understand, but it's based on the crossover frequencies in the chromosomes and the likelihood of finding a particular result in the fetus given whatever information you have in the mother and or the father. It's very complicated, but they say that they can actually give you a higher accuracy across other chromosomes such as 13, X, and Y, given this sort of algorithm. And they also give a individual score. So for example, this top one, trisomy 21, would be greater than 99 in 100. That's what that is, 99% chance of a positive trisomy 21. And that would be considered a positive result. Then these other ones are negative. So let's look at comparison between these cell-free DNA or non-invasive prenatal testing tests for trisomy 21. So these are just a bunch of trials, and basically the average of all the trials show about a 99.4% detection rate, which is very, very good. And that compares with the state of 94%, which I talked about earlier, 90 or 94%. So it's better than that. The false positive rate is also better because it's 0.15%, which is very low. In other words, only 0.15% of the population will be told that they have a positive and not actually have a Down syndrome baby. And remember I said before that 5% was what the state false positive rate was. So that's an improvement. So you have a better detection rate and a lower false positive. It sounds fabulous. The advantages, again, review the current protocol is an NT ultrasound with 2 blood draws. Okay. The non-invasive test, you just do 1 blood draw. The current protocol, you have to do between 10 and 14 weeks. Otherwise, you can't do it. The non-invasive prenatal testing, anytime after 10 weeks. You get the blood done, you have the result. It takes two results over 6 weeks or so to get the state program's results back in between your first trimester screen and your second trimester screen to all come back. With a non-invasive prenatal testing is 1 result with a 2-week turnaround time. It may be less. The detection rate is 94% with the current protocol, 99.4% with a non-invasive prenatal testing protocol. And the false positive rate is much lower with the non-invasive testing. Finally, the NT is something that's not easy to get, and requires training, requires quality assurance, requires all of us sending pictures in every 6 months. Whereas with the non-invasive testing, we don't have to do any of that. We just send it to the laboratory and it's done. So seems like it's a no-brainer. You know, the phlebotomists will now replace me and I will no longer have a job, right? Well, is that really true? Let's take a look at some of these other issues. First of all, the non-invasive prenatal testing only tests for a few conditions. And right now, Down syndrome or trisomy 21 and trisomy 18 are the 2 big ones. They make up about 2/3 of aneuploidies, that's true. But there's all these others. There's trisomy 13, which is a small fragment. There's Turner syndrome, and there's some other sex trisomy abnormalities and other rare trisomies. So we're only getting 2/3 of the pie with doing non-invasive. We might be getting more as time goes on, but we're not there yet. Also, with, if you look at the whole spectrum of genetic disease, chromosome abnormalities are only even just a small part of that. There's X-linked disorders, autosomal dominant disorder, autosomal recessive, and all these other things that aren't clearly single gene disorders that the non-invasive prenatal testing doesn't diagnose. So I think we're far from saying, you know, this is the end of the road. In addition, if we add tests like trisomy 13 and X and Y, and what I heard was just the other day, Harmony came out and are now testing for X and Y, your false positive rate is going to increase. And so even though it started at 0.15% for trisomy 21 and 18, now you're going to add some of these other abnormalities you're looking for. There's going to be some false positive rate, and pretty soon you're up to 2.3%, and it's starting to look like maybe the state program already. So the other thing is, when you look at false positive rates, which, you know, I said with the cell-free DNA was 0.15% and very low, they didn't talk about something else called failure rate. Okay, there's a whole group of patients where they weren't able to give a result, and they didn't say, okay, you're positive, you're negative. We can't get a result in you, and that was about 3.2%. It sort of varied between 1 and 5% depending on, you know, whose study you were looking at, but what if you were in one of those 3% that couldn't get a result? And why does this happen? Well, so let's look at this. This is kind of an interesting, I mean, it sounds simple to find the fetal DNA, but if you actually, you know, if it's colored gray and yellow, it would be really easy to tell. You know, the fetal DNA is yellow, and then here's 2 copies in the normal fetus, and then in the trisomic fetus, there's 3 copies. That's clear. That's not what it looks like in real life. What it looks like is this. So in real life, you have all this DNA. You can't tell if it's maternal or fetal. And there's just a slight increase here, right, that tells you if there's a trisomic fetus. And so, as you can see, this is not an easy thing to do, and it gets harder and harder at low fetal fractions. For example, if you don't have enough fetal DNA, you will see the detection rate get lower and lower. So this blue line is sort of the normal line of diploidy, so 2 chromosomes. If you have 15% fetal cells, it's going to be up here and you can tell the difference. If it's 10%, it's going to be a little harder, and then if it's down to 7%, it's going to be really hard to see the difference. And is it going to be washed out, you know, by just noise? And I think that's why there's this 3 to 4% chance of no call, or we can't give you a result, no result range. The other thing that we've been noticing, and these companies have been noticing, is that the fetal DNA fraction varies with maternal weight, and it seems to decrease with increasing maternal weight. So here we have, you know, good results, good fetal fraction up at, you know, 110 pounds or so, and then it clusters and goes down here at 300 pounds. It's pretty low, and there's a significant drop in the fetal fraction. So I think the ones that we haven't gotten results back from were in women with larger BMI. So there are some disadvantages to the non-invasive prenatal testing, and the thing is, the current protocol detects other disorders such as neural tube defects, cardiac defects, placental dysfunction, and all those come from looking at the blood tests that we do. And the non-invasive prenatal test only looks for the chromosome things. So nothing about these other things. It's the one that's covered by the state is inexpensive and covered. It's in the order of $100 or a little over, and usually the state pays for it. If they pay for testing if it becomes abnormal. A non-invasive prenatal test is not clearly covered by insurance. It's expensive, and right now I think it's around $700. There are some companies that are covering it, others that don't, and it's very unclear which ones do and which ones don't. So we have to counsel patients that, you know, it's possible they may have a bill for $700, as much as $700. The current protocol, it's unusual to have a test failure because blood is blood, and you get the results with these analytes. The NT, usually we can get it. It's very rare that we can't see the NT. But with the non-invasive prenatal test, it's not insignificant, and there are failure rates with higher weights and also lower fetal fraction. And then finally, there's validation with the current protocol by studies that's been done by the entire OB community in the United States, whereas with the non-invasive prenatal testing, that's not been validated in a low-risk group. All of these studies that showed the collection of trisomy 21 and 18 were in a high-risk group. So it hasn't actually been shown to be very useful in a low-risk group. We're just assuming that it will be. Now, is that a good assumption or not? And this may be a little complicated of a slide, but I just want to put this in your mind because I think it's just so interesting. How does a test perform differently depending on what age group you're in? Well, for example, if you're in a high-risk group, let's look at the age 38. Your risk is about 1 in 100. So let's just assume in 1,000 patients, there's going to be 10 trisomy 21s. If you're finding 1 in 100, then you'll find 10 true positives in that group, and then you'll have a 5% false positive rate. All right. So that means most of the ones that come back positive are going to be true positive, just because the incidence of trisomy 21 is higher in that group. However, if you look at a low-risk population and you have the same 1,000 people, just because the incidence of Down syndrome is low, 1 in 1,000, you're only going to have 1 true positive in that group. And yet you're still going to have the 5 false positives. And that's going to give you mostly false positives. So just because looking at the ratio, you know that because it's less likely for you to have that condition. So my point is you can't just elaborate from studies done on high-risk populations to that of low populations. The false positive rates may be much higher, and the true sensitivity may not be as high as that in the high population, or the high-risk group. So the professional society opinions, American College of OBGYN, Medical Genetics, International Society of Prenatal Diagnosis, and the National Society of Genetic Counselors came up with this opinion and sort of directive that there are recognized benefits, but it's not diagnostic. It needs to be confirmed. In other words, when you have a positive test, we recommend a diagnostic test such as CVS or amniocentesis. We don't recommend you acting on the test without these confirming tests, and should be considered an advanced screening test. In other words, a very, very good screen. It only detects trisomy 21 and 18 at the present time. It may broaden in the future. It requires genetic counseling and should only be used in validated risk groups such as the high-risk group. We need a low-risk study before it can really be introduced into the general population. All right, so that is non-invasive prenatal diagnosis. And just to make things even more confusing, there's one other thing on the horizon which is not invasive, is not non-invasive, it's invasive. So it's something called chromosome microarray. So currently we do these things. It's called karyotyping. You know, you probably did this in high school biology where you poked each other and got blood and then did the little spreads and you looked at your chromosomes and you look at banding. And with that, you figure out if you're normal or if you're the right number of chromosomes. This chromosome microarray is a whole different thing. You know, it looks at DNA pairs, and it has a much, much higher resolution because it's done with computers. And so whereas here with the naked eye, you can only see 7 to 10 million base pairs at the smallest, here you can see like less than 500,000 base pairs. So they can see this you can see all these little things, variations in the chromosomes that you couldn't see before using the naked eye or even using automated chromosome techniques. So you can now pick up, this is just 1 page out of 9 of these different variations on different genes and deletions. They're called microdeletions, all right? And we can now find a lot of stuff on chromosomes that we couldn't see before. In fact, in postnatal studies, that's in children with unexplained developmental delay, 15 to 20% of these children actually have something on chromosome microarray, compared with 3%. So obviously, it's a better technique, and it picks up more things, and it can explain more things. So what is the utility of this chromosome microarray if the standard karyotype is normal? For example, if you look at women who have ultrasound abnormalities on their fetus, and they get a chromosome, they get a test like an amniocentesis, and it's normal. If you do the microarray, 6% will find something. In other words, there might be an explanation in 6%. And so we're obviously missing something with just using the standard techniques of cytogenetics, and CMA is the next step. What if your fetus is normal looking, even on ultrasound? Well, it turns out if you're just an average advanced maternal age patient, 36, 37, 38, whatever, your chance of having a clinically relevant abnormality on CMA is 1.7%. Or if you have a positive screen on the state screen, it's also about 1.7%. So it's not insignificant. It's something that we are now thinking maybe we should do. But in which situation should you do it? Well, we're now offering it in this last one where you have ultrasound abnormalities. But the question is, eventually will we be offering it to all older women, people with positive screens, or just everybody? And of course, it's never that simple. I mean, this is kind of a complicated slide, but I just wanted to make a point that with everything we know, there's these variants that we sometimes don't know what they mean, and that's called variations of, I forgot what that meant. Anyway, but it's variants that we don't understand. I forgot what the U stands for, but it's basically things that are of uncertain significance. That's what it stands for. Variations of uncertain significance. And the study in 2007 found about 2.5% of the women had this uncertain significant variance. And then when they went to look at it, about 0.9% were actually pathogenic. If you go back and look at those data now with 2012 classification, now that we know more about the different microdeletions, they have found that a lot of these uncertain significance is now moved over to the pathogenic side. In other words, they now have a phenotype that we can say, oh, this is abnormal. So now if we see that result, instead of in 2007, we would have said we don't know what it means. Now we can say, yes, it means this. So it seems like the more we find out, the less this uncertain category will be an issue. So should chromosome microarray replace karyotyping as a primary prenatal diagnostic test? Well, it seems that perhaps, because it's a higher resolution and it's amenable to automation and quality control procedures, and it's also faster. It seems better and it's faster. So perhaps the old style prenatal diagnosis is going out the door. This with NT, and perhaps we're moving into a new region of prenatal diagnosis. But remember the CMA still requires tissue, so that means you still have to offer amniocentesis or CVS to women who want to have this test. And I think what we're looking for in the future is something where we're able to achieve the intact fetal cell in the maternal circulation, and then take the DNA from the fetal cell, and be able to amplify the entire genome and do microarray on that. That would be the actual goal. That would carry no risk to the pregnancy and yet give you all the information of microarray. I think that might happen. I don't know. We've been looking for the cell for many, many years, and it hasn't shown up yet. And there are some ethical issues. If that were possible, we have to ask ourselves, if prenatal diagnosis carries no risk, is this going to be a method of sex selection or some other type of gene selection with direct consumer access through the internet? Is this a good thing because there's not that medical advice or support that comes along with genetic counseling? Is this going to affect our pregnancy termination rates? And then in the future, what will this mean for the child who will have all this information about himself that he never really needed, maybe didn't want to know? And then to end, I just want to show you that it's getting murkier and murkier, that there are these tests now that are available online from these companies where you can just even do a swab of your cheek and figure out if you have any of these 100 genetics diseases. Are you a carrier for any of these things? I think these are problematic. These women come in and say, well, why can't I get this done so I know if I'm at risk for any of these things? Well, there's many reasons why you shouldn't. The reason that screening occurs and the reason it works is because the professionals have gone through and looked at the data to decide which tests are actually at a high enough detection rate to make screening feasible. For example, cystic fibrosis. For example, Tay-Sachs disease in the Ashkenazi Jewish population. If you start to take it out of context and you're saying we can screen for mucolipidosis, if you look at actually the detection rate, some of these have really low detection, like 45%. So it doesn't mean that much if they tell you you don't have it because it's only a 45% certainty. And the ones that they give you a 99% certainty, we already know about. They're Tay-Sachs in the Ashkenazi Jewish population. They are cystic fibrosis in the Caucasian population, and those things. And they're already being offered routinely. So getting the whole 100 disease panel it's unclear whether this is an improvement, and it's also very confusing for the patient. I can talk more about this, and also there are different panels depending on which company you use, and I think they just go through and randomly pick something to get to 100 sometimes to screen for. So our choices are getting more and more complicated. It looks like ultrasound will still be around for a long, long time. Amniocentesis and CVS I think will not go anywhere until we find that fetal cell maternal circulation, which might be a while. There's a cell-free DNA that I think is definitely playing a role. And then as this comes up, then this first trimester and second trimester screen may be exiting, and I think soft markers is really going out the door. Once we have cell-free DNA, which is a much, much better marker for trisomy 21 than some of these ultrasound markers. So I just want to leave you with the idea that the choices often involve pregnancy options, and we want to make sure they're educated options, that we don't just buy into the latest and the greatest, and that we can just order the more the better, that we actually should understand what these tests mean, because without that understanding, I think it becomes very, very confusing. And the children that we are trying to serve and the resources that we have for helping their lives become as rich as possible. And then finally, I just want to acknowledge the people that are in my life and work, the people at the Prenatal Diagnostic Center, my techs, the genetic counselors, Dr. Mary Norton, who I borrowed some of the slides from, and the pediatric radiology group that helped with the MRIs. So that's all, and any questions? Yes.
You said the state sets criteria for the screening.
Yes.
Does that vary from state to state?
Oh, so that's interesting. California is the only state that does that.
What do other states?
They do whatever they want. There's nothing, I mean, there are some recommendations that come out from American College of OBGYN, like the second trimester screen and the nuchal translucency, but there's no central place that says we should offer it, and there's nobody that says if you don't offer it, that's a bad thing. Yeah, and so a lot of these states, they have no guidelines. They just do whatever they think is the standard of care. And with the cell-free DNA coming out and people coming to bring them lunches and bring them brochures and say, offer this test, it's great, it's better than the old test. They don't know the difference. Why not? It's. I think that's what they're hoping. That's what the companies are hoping for, is that they'll do that.
If one is interested in becoming a genetic counselor, what is I noticed the National Genetic Counselors Society Association.
Right.
How available is that, and the qualifications you need and all those questions?
I believe they go to school for a number of years. There's a genetic counseling degree that they get. I don't know if it's 2 or 3 years. I'd have to ask one of my counselors and see. That National Genetic Counselor, that's sort of an association they belong to after they've done their training and take the boards. There's a board exam.
I thought I heard that there were some things that amnio screened for that the CVS doesn't. Is that true?
In general, no. I mean, there might be some metabolic disorders that you need to have the enzyme. I don't, you know, it's very rare, very rare. Mostly the amnio does give you some information about the neural tube defect, which the CVS doesn't. So there's an enzyme called acetylcholinesterase, which is released from a neural tube defect that can be found in amniotic fluid. So that's probably what you're relating to. So if that comes back positive, then you really have to go searching for that neural tube defect. The honest truth is that, you know, ultrasound's so good now that we pick up 99%, I think, of neural tube defects without that knowledge, because we look carefully at the spine. But obviously, if you came to me with an amniocentesis that had positive acetylcholinesterase, I would look even harder. I would keep looking until I found it, basically. So that might be one advantage of the amniocentesis. But a lot of people who do the CVS, they just, you know, make sure they do the blood test, which is the screening for the for the neural tube defect in the blood, and then if that's negative, then they're good.
Is that blood screening done close to the CVS time?
So the CVS is first trimester and it's up to 14 weeks, and then the second trimester starts at 15 to 20, and that's a blood test that is done in a physician's office, and that you can do, if you had a CVS, you can do just the AFP. That's the one for the neural tube defect. You can skip the other risks because you've already figured out whether you have trisomy 21 or not. So you don't want to confuse yourself by getting more information that's not necessary.
Great, thanks. So who are you offering the Harmony to?
So here's what happens. For example, if they come in and their test is positive. So let's say you're screen positive. It's 1 in 150 after the second trimester screen. You have the option of doing an amniocentesis, or now you can do the cell-free DNA. And if you do the cell-free DNA, it's almost like doing the amnio, because if you get a negative result, you're 99.4% assured that it's negative. If it's positive, then they still recommend doing the amnio to confirm that. So some people who don't want to do the amniocentesis will decide to go with that. Other people say, well, you know, but the cell-free DNA only tells me about trisomy 1821. I want to know everything now, even though my risk is really for trisomy 21. I'm worried enough that I just want the whole array, and I'll do the amniocentesis. So it's confusing because, you know, do you go and do the non-invasive test and just learn about trisomy 21 and 18, or do you do the invasive test, learn about the whole karyotype, or even the chromosome microarray, which is now sort of coming around? And some people are saying you should offer that to everybody. I don't think we're doing that yet, but we're certainly offering it to people who have some ultrasound abnormality.
And I know it's sort of like that edge of the ethical question at this point. What do you know so far in terms of like the choices, the termination choices, and all of this around this whole issue? Like, I'm in bioethics and just entering the field, so I'm wondering about what are things, what's happened, where is this now? These questions.
Yeah, I think they're more and more complicated, especially you know, that ethical side, especially when you have all this information about your fetus or about yourself, carrier frequencies and things like that. Is this the right thing? You know, what do you do with that kind of information? Are you allowed to do this even if you had no consent from the fetus? Is it ethically good to be able to do a swab or something like that and find out if your fetus is male or female, you know, and then decide based on that in the future, be able to do something about that? I think there are a lot of issues that need to be addressed, and the problem with the tests the way they are is that they're on the internet and they go directly to the patient. They don't go through the doctors. You know, they're hoping that the doctors will use them, but you can also just sign in and do it yourself. You don't need to have any prescription. And it's hard because sometimes it comes with no counseling and no understanding until you have a positive result, I think. And then, you know, everybody scrambles to figure out what that means. Sorry.
Just clarify, I'm gonna make you say it one more time.
Sure.
So you're not having the cell-free testing replace your state first trimester screening, you're using it more when you get a positive.
Right,
Okay.
right. So here's the thing. Now, if I worked in Washington, I can do whatever I want. But in the state, this state, we have to offer the screen until the state says you don't. And so this kind of happened when nuchal translucency came out, and the state had not adopted it yet. You know, we had to tell people, you still need to do this other stuff, but there's this new thing coming out, and you can pay for it privately if you want, but the state doesn't have anything to do with it. Now it's the same kind of thing. You know, the state says you should do the nuchal, you should do the test, blood test, and if you do the cell-free, then it's all up to your own, you know, your own risk and your own payment. I think that eventually they may have to incorporate this test because it's such a higher such a higher detection rate. So they, you know, somewhere down the line might be offering a cell-free thing. Or down the line, I think what's going to happen first is that if you're screen positive, they'll probably pay for the cell-free DNA. That'll be the first step, right? And then eventually maybe they'll get rid of part of the screen and just substitute with the cell-free DNA. I don't know if the nuchal test is going to go away because I think it detects other things, you know, besides just chromosome abnormalities. It detects cardiac anomalies. Just the fact that you have an ultrasound that early, we picked up a bunch of abnormalities early, which is great for the patient. So not to have that opportunity to have that ultrasound, I think would be not an advantage for the patient. But
If you lived in a different state,
yes.
what would be your ideal? Like, what would you do? What would you counsel patients to do?
Oh, now this gets complicated.
Do I
Because,
just ask you that?
yeah. Okay, so if the cell-free DNA were free,
Okay.
let's say, I think that's the best screening test for trisomy 21 and 18. I do. Now, you're giving up other things when you don't do the screen, the blood test from the state, you know. And so my own patients, I will say, I still would like to draw the blood test because it tells me about your placenta's function. In fact, I just had recently a patient of mine who did that. And she has a very bad history of miscarriages. So we decided to do the screen just purely to see what her placenta was doing in this pregnancy, and that was very helpful to me. So there's other information, there's a neural tube defect information that, you know, the cell-free just doesn't get. And so I sort of like to do that and the blood test. Do I recommend amnio on everybody? No. I think if your cell-free is negative, why would you? I mean, you know, it's going to be negative. Down the line, do I think it's worth doing an amnio to get a microarray, you know, that 1.6% if you're older than 35 of finding something? Maybe, you know, maybe I'm anxious enough to find those little micro deletions. And but certainly if there's an ultrasound abnormality, I would definitely do it. I would do an amnio and I would get the microarray or a CVS. So I think you have to sort of individualize every situation, but I think the problem is it's so complicated. Sometimes patients don't know what to do, and they do everything. I've had people do first trimester screen with nuchal and blood, and then they come back and they have a cell-free DNA, and then they have an amnio. So they, you know, so they felt like they got the best because they did everything, and that some of that doesn't quite make sense. But that's the nature of the conditions right now. Yeah, yeah.
Just very briefly, how can you tell about the placenta from the blood?
How can you tell?
About the placenta.
Oh, I see, from the blood test. Yes, so the analytes, the proteins that are in there, are high in certain, when they're high, certain ones are high and certain ones are low when there's a problem with the placenta. And papers have been written about this, and we know which direction they go. So if, for example, your PAPP-A is less than 0.29 multiples of median, that's kind of a red flag. If your inhibin in the second trimester is greater than 4 multiples of median, that's a red flag. If several of these are off, then it's a really big flag. And so that will help us when later on the baby comes back and it's growth retarded by 3 weeks already, by 20 weeks, or something is going on that makes you wonder, why is this fetus not normal? Is it genetic or is it placental? And so some of that information can be gotten from the serum screens, I think. It's a complicated algorithm, but we have all kinds of things on the wall to help us remember which way the analytes go and what that means. So, a lot of information. Yes.
Not quite on topic, but I read a story a while ago of a woman who had a male liver. Her liver was in trouble when she was pregnant, and some stuff leaked through found a nice home and settled in and did its thing. Have you heard that story? Does that make sense?
I haven't. No, so I'm sorry, did she have a liver transplant? Or no?
No. Her liver was in trouble when she was pregnant.
Yes, and then,
And a stem cell or something that leaked through the placenta found a home, and a liver that needed regeneration, and it settled in and turned into a liver. And I think they checked it, it matched one of her kids. The DNA matched.
you mean her liver changed?
Yeah,
Her liver changed?
yeah.
I'll have to look at that story. I don't know how that, I'm not sure how that would happen. You mean so she was pregnant and some stem cell from the fetus
Yeah.
came into her liver and populated and then grew a new liver that was a different karyotype? Oh, that's interesting. I don't know. I've not heard of that, but it's like an autologous bone or liver transplant or something. Interesting.
I think it was in one of the popular, biology or medical books, but I haven't been able to find it again.
Well, I mean, they're certainly trying a lot of things with stem cells, if we could do that with everybody, that'd be amazing. I don't know that we're there yet. Otherwise, people would, be getting new organs without having to deal with cadavers. Yeah, I think so. I'm happy to answer other questions if you have.